It's great.
So,
I love it.
actually, I was getting to
Together with Ron and David Kim and Ron Nevins, of course, we did a study in Riyadh University in which we tested the different behavior of different surfaces, because we would like to understand if we need a rough surface or not. There is a difference in the regeneration pattern in the two different surfaces. So we randomized the position of the implant, and we treated 6 dogs with 18 machine surface implants and 18 with a rough surface implant, an oxidized surface implant. And we did histomorphometry and histological analysis. And these are all, this is the study protocol: tooth extraction, 3 months of healing, and implant placement, and 1 biopsy immediately after the implant placement to see what happens when we place an implant. Another biopsy the day after to understand after 1 day what happened. After 1 week, 2 weeks, 1 month, and 3 months, the progression of the bone regeneration on the implant surface to understand if the surface is really influencing the bone regeneration, the osseointegration. If you look at the first, this is the oxidized surface, the rough surface, immediately after implant placement, we have a bone-to-implant contact very low, 25%. And you can see here that we have a contact between the threads, between the implant surface and the bone, just with the tip of the threads. But there are wide areas in which there is a contact only between the implants and the bone chips that we create with the burr. If we look at the machine surface, same day, immediately after implant placement, again, 24%, very low bone-to-implant contact. This means that it's caring to do immediate implant loading, because we have to know that we have a very low contact. And again, we have a contact between the tip of the threads and the native bone, but in between we have just coagulum and bone chips. Second day, the day after, where this is the period in which we do immediate implant loading, you can see we have exactly the same situation. In this case, the rough surface has 17% of bone-to-implant contact, and again you see all the bone chips in contact, and the tip is the only area where you get primary stability and implant support. And if you look at the machine surface, even less, 13% of bone-to-implant contact, and exactly the same figure. Tips are in contact, the rest is not. Then we can see in the dogs, after 1 week, something is happening. This is the oxidized surface, and you can recognize that the bone chips have changed the color. The staining is different from the native bone and the bone chips. They are more red, and something is happening. Around the bone chips, you can see there is osteoid tissue and osteoblast layers. So from the bone chips starts new regeneration. It's not really starting from the surface. It started from the surface of the implant when the bone chips are close to the surface of the implants, where when they are far away, it's starting from the bone chips anyway. At high magnification, you can see here the rough surface with bone chips that are starting to regenerate the bone immediately close to the bone surface, to the implant surface. Looks like distance osseointegration, but it's the bone chips that are kind of inducing new bone formation. If we look at the machine surface, we have the same situation. Bone chips that are going to be resorbed by the osteoclasts, but the osteoclasts induce the osteoblast activity, and we have bone formation close to the implant surface, even though it's machine, smooth surface, so no difference. Look, those bone chips regenerating the bone. Then we go after 2 weeks. Here the phenomenon is much more evident. We have all the bone chips that are regenerating the bone close to the surface. Looks like osteoconductivity, but it's just the activity of the bone chips. If we look at the machine surface, same period of 2 weeks, exactly the same situation. Here is the bone is growing from the implant surface to the lateral portion, to outside. But this is not because the machine surface is osteoconductive. It's because there are bone chips here that are promoting bone formation. So it was a big misunderstanding that we had in the year 2000 when they told us that the rough surface is able to also integrate better and before than the machine surface, and that we have this kind of distance bone formation, distance also integration. And you can see here in the machine surface after 2 weeks is very evident bone formation from the surface of the implant to outside. Then let's go to, let's go to the 1 month. 1 month now, almost everything is finished. We have a higher beak in the oxidized surface, 42%, and you see that we have bone formation almost everywhere. 1 month means like 3 months in the 1 month in dogs means 3 months in the human beings. But here it's very interesting to see that where we don't have bone chips, also in the oxidized surface, in the rough surface, we have no bone formation, and the bone is coming from the periphery to the implant surface. So it's a completely different figure. You can see here the lining of osteoblasts, the line of osteoblasts that are walking to the surface. And this is the machine surface, osseointegration everywhere, about 39% of bone to implant contact. And we have a nice osseointegration, so no difference. 3 months. Now the osseointegration is complete. You can see that here we have bone formation in between the thread. The reddish bone is the new bone, the young bone, but it's complete all around. In fact, we have a very high bone to implant contact. And we have same situation with the machine surface. Here we have even more bone to implant contact, 48%. So this means to me that something strange. Only 1 implant after 3 months had the perimplantitis. You can see very well the perimplantitis here. You can see that we have inflammatory cells. The epithelium is discontinued. We have bone resorption, very evident. And that could be strange, but it's an oxidized surface. It's a rough surface. Doesn't mean anything because it's one single case, but it was a rough surface. So the conclusion could be that the bone regeneration, the osseointegration follows the same pattern if we have a machine surface which is smooth and the rough surface. And what is very important is that the bone chips that we leave in the space are the ones that are able to regenerate the bone. So what we need to follow when we place an implant, I skip this. I have still 10 minutes or finish? Okay. So the conclusion for me is we don't need to have rough surface at all. Or if we think that they are important, don't place, please companies, don't place the rough surfaces close to the implant shoulder. Leave at least 4 or 5 millimeters. Make hybrid implants with, if you want to make a rough surface, put it in the apex of the implant, but leave half of the implants machine and smooth, because we don't care so much about increasing the percentage of success of 1%, but we want to have our treatment that is predictable over 10, 20, 30 years like we had in the past. So I recommend to use or machine implants or hybrid implants with half of the rough surface just at the apical level.